Hi, and welcome to another episode of the Healing Lyme 2.0 Summit. I'm your host, Dr. Mariah Hinchy, and today we are going to be talking about the very important topic of how to make a clinical diagnosis of various vector-borne diseases, including Lyme, as well as talking about common pitfalls with testing and the importance of using a specialty lab when we do test. So joining me is expert Dr. Joseph Burrascano,
Hi.
and Hi. He is a physician who specializes in the diagnosis and treatment of Lyme and associated complex infectious diseases and the chronic illnesses that accompany them. He's best known for his educational presentations and for his monographs on diagnostic and treatment guidelines for Lyme and related tick-borne illnesses. This is a classic series that has been freely circulated around the world since 1989. He has decades of experience and research in this field and has appeared on virtually every form of media. He has advised the CDC, the NIH, he's testified before the US Senate, and he is also a founding member of ILADS, the International Lyme and Associated Diseases Society. He's also served as the director of the ILADS Educational Foundation. Welcome, Dr. Burrascano. Thank you so much for joining us and sharing your immense knowledge on this
Pleasure.
topic.
Thank you for being so nice.
Of course. All right. So before we get into the clinical diagnosis piece, let's dive right into the testing. So obviously, we know that conventional laboratories are so flawed when it comes to testing for Lyme and co-infections. But there can even be issues as far as timing and knowing what to test for when it comes to using specialty labs. So let's just start with the very, very basics. We have direct tests where we're looking for genetic information from the actual infection. And then we have indirect tests where we're looking at the patient's immune response to that infection. Can you kind of walk us through the two and kind of go over pitfalls regarding the two different types of tests and when one would be appropriate over the other?
Sure. To understand the testing, you also have to understand the body and the infection and the interaction between the two. So let's say you have a tick-borne infection, you get a tick bite, and you start to get sick. Well, in the very beginning, the numbers of germs in your system start to rapidly increase because the immune system hasn't matured yet and hasn't been able to fight it off. Over a period of weeks, the immune system starts its recognition and starts to build up antibodies and T-cell responses and so forth. And gradually that starts to work and the number of germs decreases. And over a few months, especially if treatment is not given, the immune response matures further, usually, and testing of indirect things like antibody levels becomes the way to go. But over a period of time, if it's a chronic infection, meaning 6 months to a year or more, the immune system starts to become dysfunctional, and the germs which have been suppressed by this immune system start to grow back in higher numbers. Number one, because of this dysfunction of the immune system. And number two, the germs adapt to the host. So they know how to live in a body. That's their nature. So what that means is different phases of the infection are best approached with different types of tests. Starting very simply in the very, very beginning, let's say you have a tick bite and you start to develop a bump at the bite, or you think, gee, I was bitten 3 or 4 days ago and this is starting to react. Is there a test at that point that really works? Probably not, okay, unless you want to biopsy the skin and look at it. But even then, where do you send the biopsy and who's going to look at it and how accurate is it? However, by the second week, even by the end of the first week, but more into the second week, you can start to get the early immune responses, and that can be measured best by a T-cell response assay. They call them LE spots and a number of different chemical names for them. But immune cell response by T cells is the first one. Now, in some infections like babesiosis, you can get direct testing, and the kind of direct test for babesia usually involves looking at a blood smear. And that also is very good early in the infection because that's a higher germ quantity and a lower immune response. So what kind of blood smear do you get? Well, if you went to a hospital, they'll put a drop of your blood on a glass slide and put the same kind of stain on it that they used to look for blood cells, and look under the microscope. And they sort of count cells, and gee, every so often I see a parasite floating around or not. The accuracy of that depends on the microscope, the bulb in the microscope, the quality of the stain, and the technician's training and how long they decide to spend on the slide. 5 minutes, 10 minutes, half an hour. It all varies. So to get a more accurate test, they developed what's called a FISH, a fluorescent in situ hybridization. Now, it's still a blood smear, a drop of blood on a glass slide, but instead of using a regular stain, which is like ink, they use a fluorescent stain that binds to the RNA of the germ. Now, that's very good for a few reasons. Number one, when you look under the microscope, instead of a regular bulb, use a black light, and the thing lights up like fluorescent. You can see it really easily. So it's much more sensitive of a test, by 100 to 1,000 times more sensitive. Also, this dye, this fluorescent thing that you'll see, it penetrates biofilms. So germs and biofilms can be detected. And the second thing is, because it's a specific test, it binds to the RNA of the germ, or the Babesia. They have it for Bartonella as well. You're not going to get a false reading from, say, a different parasite. It's not going to pick up malaria if you have Babesia. It's not going to pick up a different bacterium. It's not going to confuse a platelet with a Babesia organism. So early on, for Babesia Bartonella, a FISH test is very good. Early on for Lyme and Borrelia, the T cell response assay is good. By the third week, between the second and third week, is when an immunoblot from IGeneX starts to become sensitive. And we've seen that clinically even as early as the end of the first week, but that's kind of the exception. And in fact, in testing by using CDC samples, early Lyme, and by the CDC's definition, which is getting a rash, they picked up 93% of the cases. So if you're into like the first several weeks of the infection, you can get an indirect test like an immunoblot that's available for Lyme and Babesia, Bartonella, and so forth. So that's a really good way to go. Now, let's say you've been exposed to a tick. You didn't really know you had a tick bite, but you're suspicious of it because a few weeks later you're starting to feel flu-like and headache, and you're not feeling well, and then your knee starts to be sore, and you're forgetting where you put your keys, all those things. And you forget your kids' names, and you call them by the dog's name. Anyway, so you say, I want to pick up Lyme disease or one of those. At this point, an indirect test, like an immunoblot, for example, or the one home test called the AccuDart, those are really very good because, again, the pickup rate is between 80 and 90% of the average tick-borne infection. And again, they're available for Lyme, relapsing fever, Borrelia, for Babesia, Bartonella. Now, what about a rickettsial infection? Rocky Mountain spotted fever, Ehrlichia anaplasma. They're different. Most of the time, they're acute infections. You get sick within a matter of days, 2 weeks, you have a fever, have a really bad knife in the head, kind of a headache. You may or may not get a spotted rash on your hands as well as on your arms and legs. And that's important because if you get an acute infection with one of these, that can become rapidly fatal, believe it or not. We have seen fatalities from undiagnosed patients. But that's much more of a clinical diagnosis. And the serology tests for that really don't become positive right away for the first couple of weeks. And, the typical story is you hear someone be admitted to a hospital with acute fever and very sore and everything else. And low white count is another sign of this, or low platelet count is another sign of this. Sometimes liver enzymes go up. And they think they have sepsis or some non-specific infection. They give a general purpose antibiotic, which doesn't kill these rickettsias. And the person gets sicker and sicker. Sometimes they die. So the index of suspicion is high, and you have to treat it with a specific antibiotic family, like the doxycycline family, tetracycline family, sometimes others. And that's where the clinical diagnosis really is very important.
Right.
When you get into a chronic infection, that's when the immune system starts to break down. In my own patients, I start to see that about 1 year, where it's really pretty clear. Others have seen it as early as 6 months into the infection. That's different. That's when all the tests become less sensitive. The germs have adapted to the host. They evade the immune system. So antibody tests like immunoblots, serologies, ELISAs, Western blots become less sensitive. The germs form a complex with the antibodies, and they bind to each other, and they're no longer freely available. The antibody is no longer freely floating around in the bloodstream. So if you do a test looking for antibodies, you may not find them just because they're sequestered, they're hidden. And that's why when you treat the patient, sometimes the antibody test, which was negative, becomes positive, which was a low positive or indeterminate, becomes a true positive. Or if you get a Western blot or immunoblot, the number of bands increases because you're freeing up antibody. So if you see statistics like our test will pick up 80% of the infections, well, these are people who are not chronic, who don't have this immune complex problem. So that's why we say, you know, it's always a clinical diagnosis and the testing can be negative in a true positive patient. Now, in someone who's very sick, very advanced Lyme, other tick-borne diseases, you have a poor immune system, you probably have built up toxins, you probably have yeasts going on, you know, all the other things. And in that case, you really need to use a combination of different types of tests to get a broader picture of what's going on. So in that case, you definitely want to try and use both an indirect test like an antibody test and a direct test like a culture or a fish test or a blood smear. And that's it in a nutshell. We could go into specifics if you want.
Yeah, I have a question. So, why is the fish only available for Babesia and Bartonella? Because it's more accurate than doing a regular PCR, correct? Why isn't
Generally,
there one
yes.
for Lyme?
T-Lab does offer one for Borrelia, but you know, Lyme is more of a tissue infection than a bloodstream infection. And yes, they do transit through the blood. People say, well, they don't live in the bloodstream. Well, that's ridiculous. How does a tick get infected when it drinks blood? It's definitely in the
Right.
bloodstream, but it zips by really quickly and in small amounts. It also is not steadily in the blood. They attach or adhere to the lining of the blood vessels for a while, and then they release and they run along, they attach again and release. So it might be intermittent amounts. So
Yeah.
taking a direct test in the blood for Borrelia, especially Lyme Borrelia, is really not that sensitive because of this intermittent phenomenon. If it's in
Right.
the
Versus
tissue,
Babesia that likes to live in the red
yeah, and
blood
they
cell,
live in
right?
the
And
blood
Bartonella. Yeah.
cells. Yeah, red babies and Bartonella tend to have at least part of their life cycle in your blood cells. So if you look at the
Right.
blood, you see it. You know,
Right.
but Borrelia live in the tissue cells. Now, if you did a biopsy of someone's heart or their brain or some other thought part, then you'll be able to see it on a fish, and that's what T-Lab offers.
Right. Okay. So to summarize for everyone listening, so really getting tested within the first couple days of getting a tick bite, as far as doing tick borne disease testing, you're typically not going to be very accurate. But within the first 1 to 2 weeks for Borrelia, you could have a T cell assay. And for Babesia bartonella, you could do the fish test, and
Yep.
those would give you the highest levels of accuracy. Do you know specifically? I think you said for Babesia and Bartonella fish, it was like 96%. Is that, did I hear you correctly?
No, for Borrelia in the immunoblot test, which is a serology, by the
Hmm.
time the rash develops, it picked up 80, I'm sorry, 93% of cases in one of the
Oh,
series.
gotcha. Okay.
Okay. Um, Babesia is different. You know, if you went to the hospital, an acute infection, they suspected Babesia, they looked at the blood smear at the standard microscope and dye and all that. Um, that's only accurate in the first week. The CDC claims the first 2 weeks, but in my experience, by the first end of the first week, the germ count goes lower because they start to sequester, they get stuck in blood vessels and blood clots. The immune system starts to fight them off. Um, so that's when you have to go to a more sensitive test like a fish. Now, was the
Okay.
fish 100%? No, because like you go, you're going to use a different word of fish. You go fishing in the ocean, you don't always catch a fish, but doesn't mean they're not there. So you
Right.
have to be lucky in a sense and catch it. That's another thing that we often do is more than one blood test. You know, the labs will test a small volume of blood. So you draw 2 or 3 tubes. You do it a few days in a row. I know Galaxy Labs, for example, when they do a Bartonella testing, they want 3 separate blood tests sent in separately. It gets expensive and takes a lot of time, but that's the state of the art right now, unfortunately.
Right. Okay. And so then once, if you're going to use an indirect test, so the first two, the T cell assay and the fish are direct. If you want to use an indirect test, like an immunoblot, then for IgMs, peak production is around 3 to 4 weeks. And for
Oh no,
IgGs,
no, actually an IgM could be the end of the first week.
Okay.
with a IgG immunoblot. I mean, that's what we've seen. With a standard serology like an IFA or ELISA, even a Western blot, you really have to wait 4 to 6 weeks.
Okay.
The immunoblot is
So
a different technology totally.
so if you're doing an IgM immunoblot for Borrelia,
Yeah.
what week would you recommend waiting until for peak IgM detection?
Week number 2.
Week number 2.
Well,
Okay.
that's not the peak. That's the beginning of it. The peak is the 4th week, but the
Right.
beginning, at least by the 2nd week, if not earlier.
Okay. So peak production is 4th week for IgM. And
Yeah.
then for IgG, what would be peak week production? Is that around week 6?
Generally, you don't see that in good amounts until the 4th week or afterwards. But the
Okay.
paradox is, see, some people with Lyme don't develop a positive IgG ever. Now, the dogma in medicine and infectious disease and immunology is you get an infection, right away you start getting an IgM response that disappears after, say, 4 to 6 weeks. And then you get an IgG response that takes over and that persists until the infection's long gone.
Right.
Lyme, however, because of this dysfunction of the immune system, sometimes you only stay with IgM and it never converts to IgG. And that's where a big problem with testing comes in. So when we want to talk about specifics of testing, we'll go into that as well.
Yes, definitely. So first, though, I want to say there are a certain number of patients, right, that are seronegative, that do not make antibodies, or they make antibodies that are so low, especially with IgGs, as you were just saying,
Yeah.
that they could get an indeterminate. But I think it's important for the listeners to understand this point. So, even if you're using a specialty lab like IGeneX, and let's say that your test comes back negative, because indeterminants aren't counted as pluses for anyone who has seen an IGeneX test. We have to know how to interpret this test as a clinician. And for our patients, our listeners who are patients listening, your doctor has to know how to look at these tests as clues or supportive evidence that your immune system has been exposed to this infection and to the various proteins that are being analyzed. Because if you have indeterminate levels of antibodies, it's still showing that your body had to have seen some of this to be able to make that immunological reaction. And if we think about it from just a common sense standpoint, we're looking for an infection that causes immune dysfunction and oftentimes immune suppression or antibody suppression by measuring antibody levels. So I always say, like, we have to look at any detectable amount of antibodies seriously, especially if the person has the clinical presentation of these infections.
Well, the answer is both yes and no.
Okay.
All right. It has to do with testing technology. Okay. When you say an immunoblot, truthfully, an immunoblot as a generic term is any kind of a blood test for an infection where you separately look at the different antibodies that are formed to it. So immunoblot's like an umbrella term. A Western blot is a form of an immunoblot. When we talk about an IGeneX immunoblot, that's a specific thing. They use capital letters.
Mm-hmm.
It's a specific, completely different test. And it's unfortunate it sounds like a Western blot because it's completely different. The difference is a Western blot, let's say for Lyme, they make them for other ones, but for Lyme, they take a whole germ, they break it into a million little pieces, and they use these to make the test. And they look for reactions to the different proteins that came from that germ. The problem is a bacterium is a bacterium. There are a lot of germs that are not specific for Lyme. You can pick up other bacteria that's typical Western blot. You can pick up viruses with a Western blot. You can even pick up autoimmune antibodies with a Western blot. So what IGeneX did was they completely did away with that totally. And the antigens they use on the immunoblot, what make the little lines, the blots, the strips, whatever you want to call it, the bands, the laboratory created synthetic proteins that are specific to the germ and germs that they're looking for. So what that means is that in some of their series, I forget, like relapsing fever, it was a specificity was 100%. There was no cross-reactivity with syphilis or oral spirochetes or viruses. With the Western blot, you can cross-react with Epstein-Barr. So if you see an indeterminate Western blot, like one band or a couple of bands that are very like weak and they're not really called positive, well, that means the body's reacting to something. It could be a virus, it could be autoimmunity, it could be a lot of things. But an immunoblot, that's different. If you see reactivity, then you know something's going on. Another thing, if you have an indeterminate immunoblot from IGeneX for Lyme, even though they say there's no cross-reactivity with relapsing fever, I would still say, you know what, there's still a Borrelia floating around. Why don't you then go for a relapsing fever immunoblot as well? And that might give you some more information.
Okay. So do you look at the indeterminate levels on specifically an immunoblot? Let's say that you're reacting to the starred bands that are
Yep.
specific. How would you interpret that?
That's some
If the
like
patient is
in that
symptomatic.
case, you're right. Then I'd say, yes, something's going on. We can't ignore it. Again, as you said, the lab tests are supportive. You know, you're a clinician, you figure it out clinically. If you're a patient, you know your body better than any doctor. You keep track, you write notes, a diary, whatever. Keep a temperature record if you have to, but you know something's going on. And then if you get an indeterminate, even on an immunoblot, it's all right. Either I'll repeat the test and just get a second opinion, you know, another second immunoblot, or maybe I'll do a direct test. I'll do a culture. If it's a Bartonella or Babesia, we'll do an immunoblot and we'll do a fish. You can get a culture for those too. So you know something's going on. And if you need to document it, then you do an additional test.
Yeah. And I
Now, in
think you
fact, I
alluded.
don't interrupt, but for Bartonella, it's very hard to pick up Bartonella. And what we always recommend, especially in established case, is you do all of them. You do an immunoblot for the indirect test, you do a fish and a culture for the direct, do all three, because there are cases where one will be positive and the other ones won't. But because those three tests from IGeneX are so highly specific, if you get one positive and two negatives, you believe the positive one.
Right. Okay. So when it comes to kind of contrasting, because I think this is important for our listeners that might not know a lot about testing, what would be the main differences between what a conventional laboratory would be looking at versus a specialty testing company like IGeneX? Just with their basic, like, if you're looking at an ELISA and a Western blot through them, like what are they missing and why?
Commercial laboratories don't make their own blood test kits. Okay. The big labs like I'll say it, Quest and LabCorp, they don't make their own, they don't grow sparkeets in a little dark lab in the corner. So
Hmm.
they buy test kits from other manufacturers, both in America and in Europe. And maybe elsewhere, I'm not sure. But test kits in the United States have to be put through FDA clearance. And now, until now, which is a whole different story, but up until now, the only test kits that have been cleared were based on a very specific single strain of a single species of one Borrelia that came from a tick and not a human being. That came from New York, from an island off the coast, and that's it. Now, the problem is there are a lot of different Borrelia in the country, a lot of different strains of that one Borrelia, a lot of different species of different Borrelia. So if you base your testing for all of Lyme and all of America and overseas on one specific germ that came from a tick and not even a person, you're going to miss a lot. So that's the dilemma. So what IGeneX has done with the immunoblot, as an example for Lyme, is that they look at dozens of different species with their fish test and their culture. They look at the genus level. So germs are in the hierarchy of genus, which is Borrelia, and species like Burgdorferi or Bartonella and Bartonella henselae. So they look at all Bartonella, all Babesia when they do those direct tests. So that way, the specialty labs will look for all the different varieties, and it really radically increases the sensitivity. And that's why so many people have clinical Lyme and they get a negative test from a big commercial lab. They say, I just read an article this morning. Well, Lyme disease was ruled out by a negative test. You never rule out Lyme disease by a negative test because there are negatives, there are a lot of false negatives, especially the commercial
Right.
labs. Now, I'll say one thing that's different is that the Lyme immunoblot, the IgG immunoblot from IGeneX now has been FDA cleared. It's not yet in production, but when it is, it's up to the private labs whether they want to use that better test. We'll see.
That would be amazing. And really, like the way that I kind of try to summarize it to my patients, because a lot of times when you're talking, you start talking about species and things like that, it gets
Yeah,
confusing. But like the analogy that I like to use is, let's say that I gave you a box of crayons that had 20 different colors in it, and you pick one out, and let's say you pick a purple one, and I say, okay, I'm going to use my test that only picks up a red crayon to tell me if you have a crayon or not, right? And then I
yeah,
come over to your purple crayon and I go, nope, it's not a red crayon, therefore you don't have a crayon. And it's like you're missing all of those other colors of
yeah,
crayons that are sitting there.
yeah,
So all of this being said, right, even though IGeneX is considered the gold standard, there's no test that's 100% accurate for the reasons that we just went through. When you're testing makes a difference, what test you're testing for makes a difference, even knowing what to order, right? As a clinician,
yeah,
if you don't order the right test, then it's not going to come back positive either. So, taking all of that into account, these are clinical diagnoses that should be made for these infections. So, let's move into the clinical diagnosis. So, let's start by going through what you would consider to be kind of the most typical acute presentation of Lyme. And let's contrast that with the most typical, which is kind of laughable because it presents so many different ways and so many
yeah.
different people, but the most classic chronic presentation of Borrelia.
Okay, we can start with Borrelia because we can do them all.
Yes, and we
um,
will.
okay. Um, Borrelia, such as Lyme and relapsing fever, generally has a slow onset. In other words, you might have had an exposure over the weekend when you were vacationing or whatever, and over the next several days, 2 weeks, you start to feel like a virus and not really well. And then instead of going away like a virus would go away, it starts to spread to other organs where you have a multiple organ involvement. In other words, you might have, as I said before, you get forgetful, you start to get headaches, you start to have pains in the joint, you get sluggish and tired. Mid-afternoon, you start to like, gee, I'd like to take a nap. So it starts to evolve into a multi-system thing. Next thing is it migrates. So you might have sore fingers for a while, and then seems to be the knee, and then you start to get more headaches that start to go away, and then you start to get something in your ankle. Something that's migrating like that is another sign of Lyme. And the other sign of Lyme is that the symptoms wax and wane once they're established on a cycle that's generally 4 weeks long. So if you keep a diary with a calendar, you can see, hey, about every 4 weeks, they seem to be worse and then better and then worse and then better. And every time you get worse and better, it might be a different part of the body. That's the migration. So Lyme is a multi-system, migratory, and cyclic disease. And that's why when clinical diagnoses are made, you need to, either be a very good historian to yourself, which you never are with Lyme brain. You
Mm-hmm.
keep a daily diary, and that's what I always recommend. And as a physician, you need to say to the patients, tell me what's going on and listen to them, listen to the patient, don't dismiss it. So many times the Lyme patients are told they're crazy or they think they're histrionic because you were here last week with a bad knee and now you hear the headache. And we took care of that and it was a migraine. No, it wasn't a migraine, it was babesia. But then you come in next week and your feet and your hands are tingling and numb. They start to think you're crazy or you're trying to, make stories. But
Right.
that's not, that's the disease.
Right. And I think that's one of like the hallmark symptoms too, right? When you have a patient comes in that tells you this, they've been from doctor to doctor and they've been offered psychiatric medications and dismissed. Like it's a
Well,
huge red
especially if
flag.
you start to have headaches and your general doctor doesn't find a reason for it, and or you go to a walk-in clinic, which is always a disaster, and they send you to the
Mhm.
neurologist, and they
Right.
do what they do, and then you start to get joint pain. So go to rheumatologist, and then they do what they do, and then you start to get heart palpitations. So then you go to the cardiologist. So then you go back to the primary doctor or some other doctor and say, well, you've been to 5 different specialists in the last 5 months. You're obviously crazy.
Right. It's such a shame.
Yeah.
Okay. So moving on. Babesia. What would you say are the classic symptoms of babesia?
Babesia can have general symptoms like Lyme, the fatigue and feeling poorly and all that. But there's some other things that are clues. Some cases of babesia can occur acutely, but usually they don't. It's kind of also gradual onset. But the difference between this and Lyme is that it doesn't really have joint involvement other than just body being achy. But it does have other things. The headache from babesia is more like a migraine where you're sensitive to light and pounding and that type of thing. And the paradox is even migraine medications will make Babesia headaches respond at least temporarily. So that can be a confusion there. Another thing Babesia does is it gives you a sense of what we call air hunger. Like you feel like you can't catch your breath. Even if you're just sitting talking on the phone, you have to take a breath like that. Like, why am I short of breath? And you can go up and down stairs fine, but even sitting, you might have to take this breath. Can be a dry cough for no apparent reason. Has to do with blood not flowing properly through the lungs. Another reason, or another manifestation of that is in the brain. Aside from the confusion and all the cognitive difficulties that can be confused with Lyme, another thing that's more specific for Babesia is a sense of imbalance, where it's kind of a strange tippy feeling, like as if you've been on a boat all day, now you got on dry land. So it's not vertigo with spinning. It's not lightheaded like you got up too quickly. It's more of a tippy off balance feeling. You're walking up the stairs and I feel like I'm going to fall backwards. Some strange lack of balance. You go to a neurologist for this, they look at you with a crossed eyes, like, I don't know what you're talking about. And then they give you all these spinning tests, which you pass, and they say, I don't know what it is. Yeah. No, that's one of the signs of Babesia. The other thing is, with Babesia, you can get day and night sweats. Lyme may not be that way. In fact, it's rare to see any kind of sweating or fevers with Lyme other than a tiny low grade in the afternoon. But Babesia, you can get real fevers, you can get real sweats, day sweats and night sweats, and you're not in menopause.
With Babesia too, like with its cycle, I've heard that it's sometimes like the cycle, instead of being like every 4 weeks, the symptoms become aggravated like every 5 days roughly. Is that something that you consider to be true?
It's hard to pick them out, but if you're very diligent about keeping records, yep, there seems to be a very slight cycle of 5 to 7 days long with Babesia. Not so dramatically so, but you start to say, gee, by Wednesday, maybe it's because of work, I'm having these worse sweats, or maybe the weekend, you blame it on other things, but it does seem to have a pattern like that. But it's very, very subtle. Not everybody picks it up.
Okay. And then Bartonella, what would you say are the hallmark symptoms of Bartonella?
Again, the general symptoms, like all the tick-borne infections, you get the fatigue and the body aches and so forth. But Bartonella can do a number of strange things that differentiate it from Lyme. The most prominent one, or the most concerning one, has to do with the nervous system. Bartonella can both irritate and stimulate the nervous system, the central nervous system, the brain. So people who never had neurologic problems before can start to have anxiety, insomnia, shakiness, seizures, even pseudo seizures or real seizures. They can become, a personality change. They can become anxious, depressed. Sometimes very bad behavior can come from Bartonella. I've seen young people in institutions from Bartonella because they were violent and unreasonable. Very bad school behavior, very bad work behavior, people having road rage, which they never had before. So it's like a stimulation, an aggravation of the nervous system. We call it neurotoxicity or excitotoxicity. That's one of the most concerning things that differentiates that from Lyme. Another thing is Bartonella can get into the tissue, does get into tissues, and can cause pains in the body, but Lyme pains are specific to the joint, the tissues around the joint, whereas Bartonella pains are in the ligaments and tendons. So it's not just in and around the joint, but it can be up and down the arms and legs, all the way up and down. Could be the soles of your feet. In the morning, you get out of bed and it's like, ow, ow, it hurts to walk until you start to get moving. That's another very subtle sign of Bartonella that you don't see with Lyme.
Right. And then also the striae rash, right? And sometimes there can be like these little like tender nodules along the extremities too, right? So those are two physical findings that you wouldn't see with Lyme or Babesia.
See, the Bartonella, they call them tracks, Tracks. They look like stretch marks from a distance, but they're really not. First of all, stretch marks are because your body's stretching from gaining weight, being pregnant, whatever. And they follow skin planes, whereas the Bartonella tracks do not follow skin planes. They can be completely perpendicular to them. Stretch marks are pale and silvery, whereas Bartonella tracks are usually reddened, and they're not straight. They can be wiggly. They can be straight, but they can be wiggly as well. And they don't seem to go where stretch marks would go, although they can. So someone who knows what to look for, it definitely looks different. Now,
Yeah.
because Bartonella gets in the ligaments and tendons, our muscles are encased in like a tendon sheath, and these are affected by Bartonella as well. So if you run your hand down the outer thigh, for example, or the back of your upper arm, you might find it's tender with little subcutaneous tender nodules under the skin. And that's one of the things you see with Bartonella. With treatment, they become less tender and finally go away.
Yeah. I've seen that, and I've also seen the tracks kind of move and heal up and change. I have patients take pictures of their
Yeah.
tracks or their striae rash, and they are amazed when they see them change over time with treatment.
Yeah. And
Um,
you can biopsy those rashes and find Bartonella and Lyme in them too.
yeah, I've heard that. And then, of course, if you have more than one co-infection, which is common with
Oh,
Lyme or any of these, now kind of like all bets are off as far as what the symptoms are. And unfortunately, these infections kind of work synergistically together, right? And can actually hide out behind various biofilms together. And it sounds like we're talking about like some sci-fi movie, but like they can actually share information and almost like plot on how to like evade the immune system. So it's really important to know what you're dealing with. If you're going to be using pharmaceutical antibiotics as treatment, all of these different infections require different combinations of different classes of antibiotics, to be able to fully eradicate them. And it's so important that you know what you are dealing with, because if you have babesia and you're just treating Lyme, even if you're treating Lyme appropriately, your road to getting better is going to be so much harder, and dare I say, like, not going to happen if you're not addressing the underlying babesia or Bartonella,
yeah.
for example, infections.
And it's funny because how you respond to treatment is another clinical clue to clinical diagnosis. For
Right.
example, most Lyme medications will suppress but not kill Bartonella. So a typical story is you're given treatment for Lyme, and you have Lyme, and you take Lyme treatment, and you improve to a plateau or to a point, and you never get 100% back to normal. And if you stop the antibiotics, saying, well, they seem to be, hit a plateau, let's stop. Lyme takes weeks to start to get worse, whereas Bartonella can take a matter of 3 or 4 or 5 days to get worse. So if you have stopping treatment while you're still symptomatic, and by the end of the next week you're really sick again, that's a clue of Bartonella. So how you respond to treatment is another thing to look for that gives you a clue.
Yeah. So, Dr. Bioroscano, before we end, which I can't believe our time is almost
Yeah.
up here, um, if you have any advice that you'd like to share with our listeners, like if you could give one strong piece of advice, what would it be?
Well, first, most importantly, is believe in yourself. You're not crazy. You're not going through some life crisis, or maybe you are, but that's separate. I mean,
It could be exacerbating it.
absolutely. I mean, it's the battle of the immune system versus the germ. And if you have stresses in your life, that battle tips in favor of the germ. So, number one, believe in yourself and take it seriously and do the diary. What I recommend is you just get a calendar where each page is a month and just mark down different things each of the days, because you don't want this 20-page diary. The doctor's not going to read it. It's going to make you crazy. What you
Right.
do is you just mark down a good day or a bad day, and like the day I started to stop the medication. And this way, number one, you have a record of what's been going on. And number two, you can see the pattern. Is there a weekly cycle? Is there a 4-week cycle? Is this migratory? Those are the clues you need. Start that right away, way before you start to see the practitioner, because you want to have that as part of your history.
Yeah, that's super helpful. And also, by the time you find a practitioner and wait to get in, because so many people have such long wait lists, you could have really a solid pattern,
Yeah.
that you're looking at. And even though I guess some doctors might think that looks more crazy, I think that that looks diligent. It
Oh,
looks
yeah.
like you're trying to get to the bottom of it. You're not histrionic. You're not, you're really trying to hone
Well, if the
in, and
doctor
it's
looks at that,
document.
if the doctor looks at that and says this is not good, find another doctor.
Yeah,
A
well,
good Lyme-limited
exactly.
practitioner, whether it be an MD, an ND, or whatever, they're going to appreciate that and know exactly what you're doing. If they say this is crazy or you're crazy, don't even waste your time.
Yeah, I agree. I don't know of any Lyme literate practitioner that is going to dismiss any of your symptoms. And I think this is a huge point and a great point that you just made. If they do, then sorry, but
Well,
I don't think they're a Lyme
no,
literate practitioner.
no.
So Dr. Birascano, thank you so much for being here with us. I know that our listeners learned so much from you, as always. And to all of you at home listening to us, I sincerely hope that this has helped you and your loved ones on your journey from healing Lyme. We'll see you
It's
next
always a
time.
pleasure to have this time with you, and I appreciate it.
Thank you.